patent as they could be and healthy. So again, an ectopic can be an emergency situation. It can be a situation that's simply identified on an ultrasound, the first or second visit when a patient goes to see her healthcare provider, and addressed very simply. So you're going to see it in a variety of situations, okay, and its presentation is going to vary. Right? But it is, as I said, that's always going to be a pregnancy loss. Now, gestational trophoblastic disease, that's a whole other ball of wax. Sorry. And I'm just going to go through this, and then we'll take a big break, and then we'll do STIs, if that's okay. All right, I've got that. Okay, that's working. It's also called a hydatidiform mole or a molar pregnancy. It's an unusual situation of a pregnancy that's not really a pregnancy. Okay? It starts out intending to be a pregnancy, but it's not. And basically what happens is that instead of a pregnancy developing, what develops is a large mass of what we call trophoblasts or trophoblastic cells. Those are cells that are part of the placenta. And they're the cells that secrete HCG, beta HCG, which tells someone, you know, that's what we look at on a pregnancy test. And their increased proliferation can cause other problems for the mom as well. But the way that a molar pregnancy comes about, it could be, the two most common ways would be what we call a complete mole and a partial mole. And a complete mole is a situation where there has been fertilization of an egg that doesn't have any DNA or nucleus in it. Okay, so it's an egg without a nucleus. So it doesn't have a nucleus, doesn't have any DNA or genetic material in it. So consequently, there's no cross-exchange between the sperm and the egg to create this individual person with, you know, mom and pop DNA combining to make them. So there's no fetal cells in a complete molar pregnancy. There's no identifiable cells. In a partial mole, what happens is you have a normal egg, but there's some problems because it's been able to be fertilized by two sperm, and that's not typically how things go. What has happened is that little barrier that surrounds the egg, once it's been penetrated by a sperm, doesn't shut another sperm off. So in this situation, you have too much genetic material. You may have some fetal cells, but again, they're just cells. It's not like a dermoid cyst or something like that where you have hair or you have teeth and things like that. It's just, it's cellular, okay? But they can differentiate these two types of molar pregnancies. And some of the risk factors are, again, age, because the older you get, the more you are at risk for problems with any kind of a pregnancy. So we just have to know that as a given. If you've had a previous molar pregnancy, you're at risk for another one. Anything that's used to stimulate ovulation, things like Clomid, things like that, any drugs that are used to stimulate production, mass production of eggs. Sometimes when you produce eggs in a mass quantity, quality control is not particularly good, so you may have some eggs that don't have everything that they're supposed to. The big problem with this hydatidiform mole is that one of the consequences may be what we call a choriocarcinoma, which is a cancer of the amnion and the chorion, or basically of the cells used to produce the placenta and the amniotic membranes. And it's at much greater risk with the occurrence of a complete mole, but and so it's one of these really distinct, unique reproductive cancers that only occur in this situation. Okay, there's not any other way you're going to get a choriocarcinoma but through this. And so these women have to be followed pretty carefully. So what you see when you have your patient come in and they think that they're pregnant, and maybe they've done a pregnancy test, you know, they've peed on a stick, whatever, maybe you do a repeat test, because you're looking at the mom and she says, well, I think I'm about 8 weeks pregnant, and you know, you're working in an OB clinic and you've seen lots of 8-week pregnant bellies, and they don't look like much different than anybody else's belly, you know. There's not a whole lot showing there at 8 or 9 weeks pregnant. But this particular patient looks like maybe she's 14 or 15 weeks pregnant, so she's got a bit of a bulge. So one of your first thoughts might be, if she says she's 8 weeks pregnant, but she's got a big belly, is what? She might have miscalculated, true, so the math might be off. What else might it be? What makes her belly bigger? She might have a multiple gestation in there, okay? She may have twins or triplets or something like that, you know. Or she could have this molar pregnancy situation. So maybe you're thinking, that's interesting, we'll have to measure her fundus. So the uterus is too large for the gestation. Maybe they do a repeat lab test and you're looking at the results and the beta HCG says she's 16 weeks pregnant. You try to put her on, you try to do a fetal heart rate assessment. You get out your Doptone, you put it in your ears, you try to find fetal heart rate. You're not getting a fetal heart rate. That's another, because there is no fetal heart. She says she's been doing some spotting, and sometimes they do kind of dark brown liquid spotting, and so that sounds unusual. She may say that she's feeling very, very nauseous, more than she was with her last pregnancy, so oftentimes they're at risk for hyperemesis. And then she may have an elevated blood pressure, because oftentimes they're also at risk for gestational hypertension, and it comes on much earlier than we would anticipate. And they think that's all because of this proliferation of these trophoblasts. These trophoblasts are secreting all of this beta HCG and other chemicals in levels that the pregnant body is not going to accommodate well, and so we have these symptoms. A molar pregnancy is usually always removed by a DNC. And what a mole looks like, it looks like, I'm sorry?
Both the complete and incomplete are both removed by DNC?
Yeah. A molar pregnancy needs to come out of the uterus. It's not going to get out any other way. Because a mole is basically a huge mass of these clusters of sacs of fluid. All right, so it doesn't even have any definitive borders or anything. It's just this big gelatinous mass of these grape-like clusters that are filled with fluid. And that's where the bleeding comes from, is they're filled with this sort of dark fluid, and that if these clusters rupture, then it drains, okay? So there's really no other way to remove this but to take it out and to do a DNC and make sure that the pregnancy, the molar pregnancy, is completely evacuated. They'll usually send the tissue to pathology because they want to see what type of mole it is. If it is a complete mole, they will probably check to make sure that this patient hasn't already developed a choriocarcinoma, i.e. the cells haven't traveled elsewhere during the period of time that they were in her uterus. So they may do a chest x-ray, they may do an MRI. They're primarily looking in the lungs and in the lymph nodes to see if anything's gone anywhere. It's really important that these patients in particular, if they've had a complete mole particularly, but they often will monitor everybody, come back and have their HCG levels monitored. And so this is a situation where there's a lot of education needed and a lot of follow-up. Because the risk is that in even evacuating the pregnancy from the uterus, that if there is a choriocarcinoma, that cells break off and they travel into the uterus, they go up through the fallopian tubes, they get into the belly. They travel up and attach themselves to the lymph nodes, or they may travel systemically, etc. So there's a real risk that metastasis might have occurred. The reason that they monitor these HCG levels is because that's the substance that these cells give off, right? They give off the beta HCG. So this is what's recommended right here, is that HCG is monitored every week until a pre-pregnancy level is achieved. So this is a lab test. They have to come in and have their blood drawn. Then they're monitored monthly for 6 months, and then they're monitored every other month for 6 months. So there basically is a year plus of follow-up, that they avoid pregnancy for a year, because what do you make when you get pregnant with a normal pregnancy? You make beta HCG, right? So if you have some cells that have traveled someplace and are now starting to develop a tumor in your lung, let's say, and making beta HCG, but you're pregnant and making beta HCG, how do you know that you've got the cancer? You don't, because the pregnancy beta HCG is masking the other. So they want these folks to not get pregnant for a year. So some kind of method, contraceptive method that's effective, is important. And then that they have follow-up and they have a lot of education, that they are case managed appropriately so that they're coming back to have their labs drawn. You know, they're using some method of contraceptive that is effective for them and that they're comfortable with, that they're following up, and that when they do plan to get pregnant again, that they are returning to their OBGYN and they're being evaluated from the beginning so that, you know, if there's another problem, it's identified. So, so this is one of the situations where you may see this woman repeatedly over time as she tries to achieve a pregnancy that she's able to carry to term. As I said, the choriocarcinoma, you know, you're not going to see it anyplace else. Unfortunately, it can be rather virulent if it's not identified and treated, you know, and treated aggressively initially. Yeah.
I think I missed this, but are you monitoring the HCG levels only if the carcinoma is positive, or are you going to monitor the HCG for the whole year even if it's negative?
The people who need monitoring the most are going to be the people who have a complete molar pregnancy. Some healthcare providers, and I haven't seen any definitive recommendations on this, it's kind of like the jury is out and people can do what they want. Some folks are going to monitor everybody that has a molar pregnancy. Some folks are only going to monitor someone who has a complete mole. There's not a whole lot of evidence to suggest that you can move from a partial to a complete, but there's not a whole lot of evidence that suggests that you can't. So it's like, do you know what I mean? If you have a partial mole, you might have a complete mole later in another pregnancy. So let's monitor you now and see what your risk is. So I think that's going to be up to sort of the comfort level of the healthcare provider, basically. Okay. Now, any other questions about molar pregnancies? All right, the last two things we're going to talk about have to do with the placenta. So placenta previa, has anybody had a patient who was sectioned for a placenta previa in the last couple of weeks? Anybody? No? Okay. Sometimes since we have so many scheduled sections, we'll see previas. But I haven't seen one this time in clinical. A placenta previa occurs at implantation, okay? And what happens is instead of the placenta implanting up at the top of the uterus where it's supposed to, it doesn't travel outside of the uterus, it stays in the uterus, but it goes down south in the lower uterine segment and it implants over the cervix. And so we've got some pictures here. This picture right here is what we would call a complete or total previa. So here's our placenta and here's our cervix. Okay, and as you can see, as our cervix is dilating and effacing, what's happening is that the placenta is separating from that uterine wall, and the placenta tissue potentially is being torn as the uterus, okay, because think about it, the uterus is dilating and opening, the cervix is opening, the placenta is attached to that cervix. As that cervix opens, what happens to that placental tissue? It just kind of goes, it doesn't stretch, so it's going to tear. So separating and tearing, we've got a fair amount of bleeding here, okay? This would be what we call a partial previa. So we see that we've got, here's membrane here, and here's placenta here. So it's not all the way across the cervix, but it's enough across it that we're still going to have a fair amount of bleeding, okay? And then this is what we call a marginal previa. And this is where the edge of the placenta is right at the edge of the cervix. This is kind of one of those things that's a healthcare provider's comfort level call, whether or not this is going to be a patient who's delivered by cesarean section, or if they try to see if she can labor and they'll see how much bleeding she's doing, okay? So in these two cases, you're always going to have a cesarean section. Because what would happen if you delivered the placenta before you delivered the baby? The baby's not going to have any oxygen, right, you know? So it's not a good thing, you know? We just can't do it. It's not an option. It's just not an option, okay? So the only way to get the baby and the placenta out in the correct order is to open the mom up, do a cesarean, take the baby out first, and then remove the placenta that is kind of sitting in front of the baby. So in this case, some physicians may feel comfortable doing a vaginal delivery or at least seeing how much the patient's bleeding before they decide to section her. That is totally up to them. I'm just saying that you may see that. Risk factors, again, age, other things that might put someone at risk. Yes, ma'am. Say that louder. Okay, sometimes a placenta previa will be really what we call a low-lying placenta. It implants low in the lower uterine segment like a marginal would, but as the uterus expands and the muscle fibers expand where it's implanted, it looks like it moves up the wall of the uterus, okay? It doesn't really. What's happening is that the cells in the lower uterine segment are just getting longer. They're elongating, those muscle fibers, and as they elongate, as the uterus stretches, it just looks like the placenta is relocating up higher. It's not really. It's just the cells of the uterus are changing, okay? But in that case, you might think you've got a low-lying or a marginal previa, and really you just have a low-lying placenta that basically, as the uterus expands, you realize you don't have that anymore, okay? Question? No, just, okay, all right. So basically, risk factors have to do a lot with scar tissue in the uterus. That's one of the things that they try to point to in terms of an issue with why placenta previa occurs. If there is uterine scarring in the uterine wall, then that area of the uterus is not going to be as vascular and as easy to implant in potentially. And so with women who have got multiple pregnancies or multiple reasons for uterine scarring like DNCs, lots of places where lots of placentas implanted, etc., then they may, as they progress with more pregnancies, have risk for previa because there's not as much, I guess, optimal tissue for this conceptus to implant in. Now that does not explain all of the women who've never been pregnant before and are having a previa with their first pregnancy. So that's just one of the thoughts, but it's not an unreasonable supposition. And then the other reasons, who knows? You know, the conceptus turned right instead of left. You know, went down instead of up. It's hard to know, but they happen in any woman at any time. What we see with a previa is this painless bright red bleeding. Because if you think about how the placenta functions, okay, the uterine wall brings oxygenated blood to the placenta, okay? And there's oxygen, basically, not the blood, but the oxygen, crossing at these intervillous spaces and basically oxygenating the fetal blood, which is going to travel back to the fetus and oxygenate it, and it's going to bring the deoxygenated blood back, which is going to go back to the placenta. So at the intersection of the placenta and the uterine wall, you've always got a combination of oxygenated and deoxygenated blood, okay? But you typically are going to see as the placenta kind of tears and removes itself from the uterine wall, you may see more bright red bleeding than you do dark, okay? So we kind of differentiate that as being bright red bleeding, and it's painless, because usually there's not pain involved in this particular bleeding situation. And that's different from an abruption, all right? An abruption is very painful, and I'll explain why in a minute. Now, the bleeding can occur anytime we travel up into the vagina and poke around, and that can be anything. It can be a hand, a speculum, a penis, whatever. So pretty much, patients have to be very, very careful if they have a previa about what goes into their vagina, and they may, if they're doing a lot of bleeding, they may be told that they need to abstain from sexual activity. They're not going to do any vaginal exams on these patients. They're not going to do any speculum exams, etc. So you as a nurse, if you have a patient that walks in with a previa, one of your big patient advocacy roles is to make sure that nobody puts their hand up her vagina and tries to figure out what's going on. The healthcare provider may do a very gentle speculum exam to see if anything's happening with the cervix, but there isn't going to be anybody else putting anything else up in the vagina because we don't want to stimulate either contractions or bleeding, okay? So again, top of the list, no vaginal exams. No Pitocin. We don't want to stimulate contractions, so we're not going to stimulate contractions with Pitocin. Typically, it's going to be confirmed by ultrasound. Typically, she's going to be delivered by cesarean section. And if she's doing bleeding, then she may be on bed rest at home. She may have monitoring to make sure the fetus is okay. She may be told she needs to count how many pads she changes in a day and how much bleeding's on them. She may be told she needs to sexually abstain. She's going to be given lots of education and support. They used to put these patients in the hospital in Trendelenburg when I first started as a nurse back in 1980 in OB. You know, so they were laying like this, potentially for 7 months. They don't do that anymore. So pretty much, if she's not having bleeding, she can go on and carry on her life. And some patients have a previa, they never have a problem, they never see a drop of blood. Some people begin to bleed in their first trimester and they never stop. So it's, again, you're not going to know exactly what you're going to see. But we need to be prepared to provide her with these things. All right, abruption, and then we take a long break. Has anybody seen an abruption during clinical? Okay, tell me about it really quickly. Okay.
She kept saying that her pain was not in the middle, it wasn't on either side, but it was.
Where was it?
It was very low and she felt full.
She felt full.
After I left her to go see my C-section, they said as she was waiting after she got her epidural placed, her belly got really like.
Okay.
They got her back to she had a primary C-section before to do the C-section. For this one, there's lots of clots.
Yeah. Yeah. Do you happen to know if her placenta was kind of low? That's kind of interesting, as she was feeling the pain sort of low.
No, because she didn't come in for that. She came in because she had decreased movement
Right.
and I started bleeding.
Right. Okay. Well, that sounds like a not atypical presentation for an abruption. What happens with an abruption is that we have the placenta that's supposed to be attached to the uterine wall, and it separates. And it separates prior to the baby being born. Now, we know it's supposed to separate after we deliver the baby. This time, it does it way earlier. So we have this separation. So we have decreased perfusion of the placenta, decreased oxygenation of the blood in the placenta, so consequently decreased oxygenation of blood to the fetus. All right? And the reason that it occurs is because of a hematoma, essentially, that develops between the uterine wall and the placenta. And why that develops, there's a lot of reasons, but the size of the hematoma then is determined by how much bleeding has occurred, and that, again, also determines the level or the extent of the separation. And again, what happens is then these little intervillous spaces that are the cells that, you know, reach out to each other from the uterine wall, and the placenta reaching in and embedding in the uterine wall, where gas exchange occurs, you know, get torn apart. And just instead of them being able to interact and exchange oxygen and CO2, then we just have this big, humongous mass of blood, a big hematoma. So we have loss of gas exchange, we have loss of volume, we have loss of O2 to the fetus.
Is that complete loss?
No, so we're going to look at these pictures and you'll see. It depends, the amount of the extent depends on how much bleeding there's been. All right, so this is what we call a partial separation. So here's the hematoma right here. It's like the hole in a donut. You know, here's the placenta is the donut, and here's the hematoma, like the hole in the middle. So this is probably about a 30% separation, okay? It's about a third of the size of the placenta. And so this is probably a baby that might have some symptoms. They may have some decreased movement, they may have fetal distress, but you know, as long as they're delivered in a timely fashion and the bleeding doesn't continue, they'll probably do okay. Here's a partial separation at the edge of the placenta, so you see a lot of bleeding here, and about maybe almost a half of the placenta separated. And now we're starting to get into territory where, you know, the baby is not going to be doing so good in the uterus, and it may need a little assistance when it comes out as well, okay? And then here's a complete separation. This entire area is a hematoma. It's been a massive hemorrhage. The only thing that's holding the placenta to the wall of the uterus are these edges right here where the membranes attach. So this is probably a fetal demise. This is not survivable, basically. For the mom and the fetus, we have a variety of consequences, including a stillbirth and a fetal death. Women who have a placenta abruptia preterm are going to have a preterm delivery, so then they're going to be dealing with a compromised preterm baby. They may lose a great deal of volume, and they may go into shock. They may develop coagulopathies, They may have already been at risk for those problems because they had a clotting disorder or a history of it. The fetus is going to experience hypoxia for sure. They may experience anoxia. If they are sending blood back to the placenta that's then just bleeding out into increasing the size of this hematoma, there may be some hypovolemia going on with the fetus. And again, they need to be delivered regardless of how far along they are in gestation. So this is not typically a good picture at all. Hypertension risk factors have a lot to do with perfusion issues and also with clotting issues. So you can see here that things like hypertension and cigarette smoking may increase risk with regards to perfusion, but things like trauma, cocaine use, clotting disorders may cause problems in terms of actual loss of volume, bleeding, or developing clots in places that we shouldn't develop clots, or not developing clots in places that we should. So these risk factors are ones that you might see listed for a patient. What we're going to see, this is the last couple of slides, what we're going to see is we're going to see vaginal bleeding, depending on how large the separation is. She's going to be in quite a bit of abdominal pain. I think it's interesting that she said she felt full because she must have been feeling then pressure maybe or of that change in that placenta. Abdominal pain that's quite intense, not usually covered by an epidural. You're going to have a very hyperactive uterus, which means that the uterus is just going to be contracting like this, contract, 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 because it's being irritated by all that blood, okay, and all that bleeding that's occurring. So we have this very hyperactive, very irritable uterus that just won't stop contracting. And it also has an increase in resting tone. So not only is it continually contracting, but it's never relaxing between contractions. It's just kind of in this, sort of spasmodic contraction state, contraction, 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 and it never relaxes. That way, there's no prayer for oxygen to the fetus. The fundus is very tender. That makes sense if we assume that most placentas end up somewhere around the fundus, right? So you have tenderness where that hematoma is. The belly becomes what we call board-like abdomen. Because if you've ever felt a hematoma, they're as hard as a rock, So she's contracting, she has this hyperirritable uterus, and then she has this big hematoma. So that area is very tender and very firm. And then as she continues to perhaps lose more volume, she's going to get some deferred pain to her back. Her vital signs may eventually change, but you're for sure going to see the biggie is going to be the fetal distress, okay? And remember that a mom's got way more volume on board than she would normally have as a regular person that's not pregnant. So it's going to take her a long time to lose enough volume that her vital signs are going to change, but it can happen. So I'm just saying, don't be surprised if it does or if it doesn't. Nursing care, assessment, what are we going to be watching? We talked about it a couple weeks ago. What are we going to watch? What do we see that gives us a clue that this might be a problem? Or what are we going to watch to see if it's a continued problem? We're going to watch that fetal heart rate monitor. Absolutely. We're going to be looking at the contractions and how they're changing. We're going to be looking at fetal heart rate. We're going to be looking for those late decelerations, that sign of fetal distress. And we're going to probably be prepping this patient for an emergency cesarean section. So we're going to be drawing labs, starting IV, making sure the physician's got the consent sign, making sure the anesthesiologist is seeing the patient, making sure the Foley's in, making sure the prep is done, whatever the prep is, getting her back to the OR as quickly as possible, trying to do teaching, trying to provide reassurance to who's ever with her, trying to also watch her vital signs, watch the fetal heart rate monitor. It's a busy time. And so here's a list of interventions, okay, which kind of all I've said. So, all right. What do we want as a goal in any situation where we have a pregnancy? Our goal is always going to be a viable newborn, right, with a good outcome, which means our APGARs that we like. Maintenance of fertility, I don't know if that'll happen or not. Sometimes women bleed so much and contract so much that their uteruses then become atonic. They just go limp, and then they just continue to hemorrhage. They have to remove the uterus. So we would like a healthy newborn, and we'd like to have, hopefully, help fertility be maintained. So for a nurse, it's picking up on the cues that we see that indicate fetal distress and that indicate a possible abruption, pain, board-like abdomen, increased resting tone, hyperactive uterus, etc., that lead us to conclude we have a problem here and we need to act quickly. All right, why don't we take until quarter after, about 10 minutes or so, and then we'll talk about STIs, okay? And if there's any questions, let me know.